Melissa, I will stop sharing my screen so that you're able to share slides as well.
Thanks very much for having me. I do apologise if you hear a dog. The heating's broken in our office at UCLH, so I'm having to work from home today. It's pretty cold in London. It's great to. Oh, there she goes. I really am going to put my dog down at some point. So I hope at some point in the next year, not only my dog will stop barking, I'm going to give her something. She's very cute. I'd love to show her to you. That I can visit you all in person, but thank you very much for inviting me at least to another Teams meeting. So I'm coming to this as a clinician, so I've led a post-COVID service in NCL since May 2020 and been working with the NHS team since September, and really just wanted to give you an update from that programme and a chance for you to fire questions at me. I won't bore you or wear you out with too many slides, but I think it would just be helpful to get this one up as a reference point, which is just covering the 10 points of the current long COVID plan and where we're at with this and what we envisage for the next financial year and beyond. Hopefully you've had some good news about the funding for next year. I think that has been sent out to regions, and I know that we're all desperate to hear a bit more certainty about that so that we can stabilise our workforce, who are now quite precious, aren't they, in helping us manage this new condition for the next financial year. So that's another 90 million for England for the coming year. And then I suppose we still don't know exactly what will happen the financial year after that, but the intention is that some transition to a more business as usual funding model is anticipated. Another feature of the 10-point plan is about collecting and publishing the data, and obviously the clinics are submitting their data returns fortnightly. Hopefully from April that's going to become a bit less arduous as we can transition more to the data landing platform, which is the mechanism by which we're building this patient level registry of the individuals being seen through post-COVID services. And that's, I think, already bearing fruit in terms of us being able to better understand the demographics of the individuals coming through, and looking to understand, the question about equity of access. I think, data is key to us being able to identify unmet need there, but I think the solutions probably rely on us on the ground in terms of identifying communities that we need to work closer with who might not be represented in the patients coming through the clinic at the moment. So the commissioning guidance has been updated and hopefully will be shared with you imminently. I think there's going to be more of a focus on the whole pathway. I think, initially the focus was very much on setting up the assessment services, but everyone's evolved and matured their pathway now, and I think there's a growing need to focus on post-COVID rehab, so there's a bit more clarity on what we feel that should include within the commissioning guidance, that multifaceted model, which I think is a real strength of your region and always has been. In terms of that sort of commissioning guidance, there's also very relevantly going to be a focus on the need to measure outcomes in our patient group, and we still have a lack of understanding of the natural trajectory and clinical course of recovery of long COVID. But we do see good levels of recovery in our patients, and we need to be able to compare different approaches to understand what are the most important interventions. And the C19 tool has been a real enabler in that regard for your region, and obviously you're going to hear a lot more about that today. And I think across the country there's a real interest in understanding how we implement the best tools, whether that is the C19 tool, for example, so that we can improve our ability to measure outcomes. It's probably one of the things that we've done the least well so far. Other things in the plan are obviously the Your COVID recovery platform. And that has come a bit more straightforwardly under NHSE control now, and there's an editorial board, and I'm hoping that we can improve the content of that to make it better and more relevant to a wider patient group, and incorporate some additional tools such as, videos that patients could watch. And then I think in recent weeks we've also felt the need to be able to share kind of live information with patients about the latest research going on in long COVID in a way that they can understand, and understand what the implications of that research for treatment might be. I expect many of you on the call have come across the microclots issue, for example, and it's a perfect example of how we need to be agile in processing information for patients and understanding the implications of research coming through, because obviously we're all desperate for any improved understanding of mechanisms or treatment options, but we also don't want to knee-jerk follow approaches that don't have a strong enough evidence base. Other points on this slide, the focus on NHS staff, and I think there's a bit more clarity on that in the new commissioning guidance, and some really good resources have been shared through the Futures site of the evolving vocational rehab offers in certain centres, I think, which is an area that still needs a lot of focus. We still have a lot of NHS staff coming through our clinic, and also other important key worker groups, teachers, for example. So in terms of other points on this slide, I think I've covered a lot of it. The National Learning Network, we have the Future site, and I think it's a good place for sharing resources and asking questions, but it's more of a forum, isn't it? And I think there's a lot more that we need to do in this space in terms of learning events. We've had 2 regional events where clinics have had a chance to share their progress and share the challenges that they've experienced, and we hope to extend that over the next year and develop some long COVID summits where clinical teams could come together to have those really important discussions. And I think one of the hard things about the field is that you're so busy, aren't you, and nose to the ground, that you can forget that people just around the corner are having the same challenges and might have come up with some good solutions. So I think events like this are really brilliant to bring people together. I would say modelling the ongoing requirements for capacity for the services remains quite challenging. The activity through your region's pathway in terms of referrals, new patients and follow-ups is high, by national benchmarks. So that's, I think, a marker of the success of the services that you've implemented. So congratulations for that. We've still got a big gulf in terms of the numbers of patients being coded in primary care versus those coming through the pathways. And I think that's because there's still quite a bit we need to understand about that ONS data, about what proportion of patients who we predict have long COVID symptoms actually do need to access a pathway such as the ones we've implemented. And of course, the big question is what will be the implications of Omicron, and we've been told that we might get a bit more of a signal on that from the ONS data in the first week of February. I don't know if you've got a sense on the ground of how that's feeling. In London, we've noticed that some of our long COVID patients have really struggled to tolerate an Omicron reinfection with a flare in symptoms, but we're hoping obviously that that's going to be short-lived. In good news, there does seem to be increasing data showing the protective effect of vaccination against long COVID. So hopefully that's going to bring us benefits at population level. But I wanted to leave some time for you to ask me any questions, so I will stop talking at you there, if that's all right. I can leave the slide up in case that's useful, but I don't know if anyone wants to ask anything about the NHSE programme at the moment.
Brilliant. Thank you very much, Melissa. Does anyone have any questions? So I can see Jennifer Davison has your hand up. If you want to go ahead. I think just ahead of that, I was going to say, I think that's a really important viewpoint to have, that national context around the priorities going forward as well, and the planning that's been put in the operational planning guidance and the further long COVID plans as well. Jennifer, if you want to go ahead.
Yeah, I was just going to ask, with the platform coming under NHS England control, the Your COVID Recovery, is there any plans to make more of the information accessible without a referral in, especially around research, etc.?
Yeah, that's right. So I think it's the phase 1 program, the online advice, absolutely is obviously open access, and that's where we would be proposing trying to develop some information about latest research, Jennifer. So yeah, that would be available to all. The phase 2 program is taken up quite variably. That's depended how it's kind of sat with local teams, hasn't it? And actually it's not what we're using in London. We're using a different digital tool, but yeah, so as open access as possible.
Thank you.
If anyone has some good ideas for specifically how that content should be improved, you know, it's always really helpful to hear your perspective. The Cambridge region have developed some really great videos, which I think show that would be a real addition. I think a lot of patients struggle just with reading content, don't they?
Mm-hmm.
Brilliant.
Thank you very much. Does anyone else have any questions? Or you can pop questions in the chat if you don't necessarily want to raise your hand and ask anything directly.
Sophie, I'm able to stay on till 2:30 and then I've got an MDT to go to,
Okay.
but I'll watch the chat for the next bit. Thank you.
Okay, excellent. Thank you very much, Melissa. So yeah, we'll now hand over to Dr. Manoj Sivan, who is Associate Clinical Professor and Honorary Consultant in Rehabilitation Medicine at the University of Leeds, and Consultant in Rehabilitative Medicine at the World Health Organization. So you can see why I just had to read that job title. That's a very long job title. So I'll hand over to you, Manoj. Thank you very much.
Thank you, Sophie. Thank you, Melissa. Can you see my slides?
We can do, yes.
Yeah. Okay, because I can't see you all. It's on full screen. Thank you for inviting me here. I'll keep this brief. So 10-15 minutes, just kind of a run through with how we developed this scale and what's the current status and what sort of developments we plan for future. So my intro has been done. That's what I'm going to be talking about. And then the digital system, I think Roman is covering later, so I'll keep the reference to that as brief as possible. This is just a kind of a snapshot of the work we've done throughout this pandemic, which started right 2 years ago. When we had the outbreak, we did a systematic review, which gave us actually a good insight as to what we're going to see in future, and that basically led us to do the study, the Leeds study, which was the first in the country to look at long-term symptoms after recovery from COVID. That's the hospitalized patients, and that's where the C19-YRS actually took birth, really, because we needed a tool to capture these symptoms in these patients, because we were calling them over the phone to find out how they're doing 7 weeks post-discharge. And as an MDT, we sat together and came up with a set of questions. And then as we talked to patients, then it went through cycles of kind of changes. And then eventually the final tool was published. The Leeds Long COVID Service then sort of started, and then there was the NICE and the NHS England guidance. And initially, I'll explain how the scale evolved, but initially it was a screening tool. But each question on the specific symptoms had a Likert scale on it. So it's actually NHS England which gave us the idea in their commissioning guidance that actually it can be used to monitor the symptoms as well, because it's got a severity grading on it. So that gave us an idea that actually it could be an outcome measure, and then hence we changed it a bit, and then it became the from the tool, screening tool, it became the Yorkshire Rehab scale. And then there have been future developments since. That's in May, June when we did that study, and it was first published in ACNR. So basically, what the tool is it's a list of about 15 questions with each symptom, which each question focusing on a specific symptom and asking the patient to grade it on a scale of 0 to 10. So 0 being no symptom and 10 being the most severe, life-disturbing severity of the symptom. And they've got to rate it at that point of time when they are being kind of interviewed, and then also actually sort of guess as to what their pre-COVID score would have been, which gives us a kind of a comparison between how the symptoms are now as opposed to pre-COVID. So that tool was taken up, it was received quite well. It got translated in numerous languages. It was, it's currently used in many countries and has been translated as well into all those languages. So in terms of the content validity of that tool, the symptoms which got picked up in that study, which was published in Journal of Medical Virology, actually was when compared to the other studies on long COVID which got published, it was quite comparable. So basically, the symptoms which were captured actually match the symptoms which were being put forward in other studies, like the Italian study, the CAFI one, which got published in JAMA, and other studies. So that basically proves the kind of the content validity of the tool or the scale. At that point, it was tool, and now it's scale, that it is capturing the relevant symptoms in post-COVID syndrome or long COVID. So I didn't cover what long COVID, post-COVID syndrome is for this audience, because I think we're past that stage now, and the audience here are well versed with what the problem is. So that was the NHS England guidance, where they suggested that we should be using the tool. So based on that, actually, we made some slight changes. We didn't change much. We just changed the kind of the wording a little bit and gave it the name, the Yorkshire Rehab Scale. So what it does is, and we rearranged the questions slightly so that all the symptoms are together, the functional ability questions are together, and the overall health is right at the end. And we also added some additional symptoms, which at the moment were sort of just emerging from the literature. So what the original version of the Yorkshire Rehab Scale does is it gives score for a symptom severity, which is on a scale of 0 to 100, functional disability score out of 50, overall health score out of 10, and additional symptoms out of score of 60. So its self-report can be completed by carers and clinicians as well, on behalf of the patient if they're not able to complete. And that's just how one particular question looks like. If you look at fatigue now and pre-COVID, how do they score their symptoms on a scale of 0 to 10? So based on that, so these are just kind of some case examples. I don't know whether you can see the numbers, but if you look at the first, so this is from the Leeds service, and if you look at the first patient, if you look at the column of symptoms before COVID, so it's only mild, sort of out, they scored 4. And then post-COVID, if you look in the month of July, the score was 29. And then those are the different time points at which the scale was completed. And you can look that in 8 months' time, in January, the symptom severity has dropped to 6. The functional disability from 17 has dropped to 1. And the overall health is actually the other way around. It's reverse, because 10 is the best health. So you can see the pre-COVID score is 10, and it's changed from 4 in July to 7. So this person has actually improved, not yet gone back to their pre-COVID status, but clearly in the last 8 months has improved. And you can see that with the drop in the symptom severity, drop in the functional disability, and improvement in the overall health. The second example is somebody which is more common of what we are seeing, not much change. And it's, as we know, it's a chronic condition, long-term condition now, and there's these fluctuations. And you can see that person from November to January, there is actually not much change in symptom severity. It was 61, it's 55, functional disability 26, 34, and overall health was 1, slight improvement to 3. But you can see their pre-COVID score was 8. So they're nowhere near their baseline, and they have not improved. Well, they have marginally improved, but not much, I would say. So that just gives us an idea of how the scale can be used in those three different domains: symptom severity, functional disability, and overall health. Something like the EQ5D has got an overall health question at the end. So it's something similar to that. So then we looked at data from 370 patients in Leeds service, and we did the validation, the psychometric analysis. So we used the item response theory measurement principles, where you subject it to analysis and you look at sort of group analysis and how the person scores on these different questions and what's the kind of reliability of the score within the scale. And when you compare that to the total score you get. And you can see there that the skewness is something which is reasonable. So it's kind of between 0 and 0.5. The table below, the Cronbach alpha, is something very important for scales. It needs to be anything more than 0.7 is good for reliability. So this is basically showing how reliable the scale is in terms of measuring the condition and how individual items actually contribute and how the person is responding to those questions. So it's giving an idea that actually it's all measuring the underlying problem, which is long COVID. And you have the floor effects, the ceiling effects, which are okay, acceptable, and then the scaling assumptions, looking at the correlations as well. I don't want to go into too much details because of lack of time. And then this is another metric, which is the correlation, and anything between kind of 0.3 to 0.8 is acceptable. And you can see the correlation between the symptom severity, overall health, additional symptoms, functional disability is of the range 0.6, 0.7. Most importantly, the overall health is a minus, because I explained to you it's the reverse way around. So the correlation is negative for overall health because of that. And that is shown in the analysis of these. So this is published work now proving the psychometric properties and validation. So then the next scale development step is to look at rash analysis. So these are ordinal scales where each individual, so all the scores are added to get a summative score, but you could really do that only if the thresholds, that is the probability of responding in those specific points, are actually almost equal. And you can see that graph where they are not actually, the thresholds are not nicely aligned. So you can see those graphs where the numbers are clumped towards the middle and there's no kind of distribution. This says that basically patients are not exactly kind of picking up the difference between, let's say, a 3 or 4 or a 4 or 5 or 5 or 6. So based on this is quite common in scale. So based on this, we had to actually reduce the response categories from 10 to 4. So at the moment, the modified scale, which has been proposed, has got only 4 response categories, with 0 to 3, the same kind of grading. So no problem to severe life-disturbing problem, but there is less choice now, and patients should be able to actually respond better in terms of between those different categories. So once the data on the modified YRS comes in, we'll do the same rash analysis, and hopefully that graph over there will look better in terms of how the graphs are. The cultural adaptation studies are ongoing at the moment in many countries, and we are involved in some, we're not involved in all of them. And we have been funded by NIHR to do the locomotion project, which is kind of a service evaluation looking at best practice in long COVID care. And we've got 10 centers. So and modified C19-YRS is one of the key measures which we are capturing in these patients, and we'll be collecting data from around 6,000 to 7,000 patients in this platform. So that gives us further data to understand and further develop this scale. Digital format, I think Roman has got another talk coming up, and he can cover that there. It's just to say that the digital system has actually other scales as well, not just the C19-YRS. So measures to capture fatigue, dyspnea, depression, anxiety, work, and EQ5D as well. So there's a choice there. It's just not the YRS, it's all the other scales as well. Just to touch upon this, we published recently on severity phenotypes that patients, they tend to fall in these 3 kind of phenotypes of mild, moderate, severe phenotypes when you look at the kind of the YRS data. And the symptom severity of the different symptoms, they tend to hang together. This is giving an idea, this is giving actually an indication to us that actually the underlying mechanisms for all these 200 symptoms we see in long COVID are probably common. There are common mechanisms driving these symptoms. So there is a lot of talk about clusters of symptoms and separating them out, but we've not seen the data yet. But this data seems to suggest that actually the underlying mechanism is something common, and it's the severity which is different. And this is reflected even in the first COVID data which came out, well, two papers really, both suggesting such severity phenotypes in their data. And this is finally, to finish up, just a thought that in terms of the WHO ICF framework, the YRS questions can be actually, broken down into these different domains. And ideally, in any condition, you would want to capture all these domains. You want to capture symptoms, you want to capture activity, participation, personal and environmental factors. And YRS actually does that in terms of the whole, capturing the whole condition. And really, it's a thought for the people here that, yes, you can have a separate questionnaire for each symptom. You can have a questionnaire for pain, you can have a questionnaire for fatigue, you can have a questionnaire for palpitation, for PEM, and for sleep, and for depression. The problem is you pretty much end up with like 15, 20 scales. And we know that long COVID is a fluctuant condition. And I think there is a need to capture lesser outcome measures more frequently so that we get an idea of the fluctuation. So if we have 15, 20 scales, how would we repeat them? So really, we need new condition-specific outcome measures which actually can capture the condition in whole, rather than using a combination of measures which have been developed in other conditions. So we've written in BMJ recently about this. I think it's waiting to be published. Those are some of the references. I can share these slides later. Thank you very much. That's it from me.
Brilliant. Thank you very much. That was a really useful presentation. I think particularly in showing how quickly this has been developed within obviously very unusual times and circumstances. We've got time now scheduled in for questions. Does anybody have any questions for Dr. Savan? Again, you can pop them in the chat or raise your hand, whichever you're most comfortable with.
Stunned silence.
Stunned silence. I think you must have given such a good presentation there that that's answered everybody's queries. I can see, I'm just trying to get your name here. Helen Duggan, you have your hand up.
Hi, just a query, and probably everybody else would agree that obviously a lot of our patients are struggling with the brain fog cognitive element. So it's just around the completion of the questionnaires. Do you tend to do that face to face or over the phone, or do they do it through computer back and forth? It's just because a lot of our patients do struggle with memory and concentration and the brain fog element.
I mean, there is a choice for this questionnaire, isn't it? They could use the app to complete, and if they're not able to complete, they can use the paper format. And if they're struggling with that, I mean, the clinicians and the carers can also help complete this questionnaire. So, I mean, there are various options. It's a very simple questionnaire, really. So those are the choices available. So there's no kind of, we're not mandating people to say that it has to be done only in one form or other. Does that answer your question?
Yeah, no, that's great. It's just knowing that we can sort of, obviously we're using a lot of those questions as part of our initial assessments anyway. So when we're doing our initial assessment, we use the Yorkshire screening tool as our basis, and obviously a lot of those questions that you've mentioned are covered within that, but perhaps we're not using them specifically as an outcome measure as such. We're recording them as part of our assessment, but we're not using it as a measurable outcome. And I think that's why for us, I'm not speaking for other trusts, but for us it's what are we using as a measurable outcome, because we've not been using the Yorkshire screening tool as a measure. We've been using it as a screening tool only.
Okay. I mean, I think the latest version, I mean, that's probably the first version of the published scale. But if you look at the future versions, they've all been kind of, they've been sort of designed to function as an outcome measure so that you get a score of it. And then so that you can see, as I shared there, the scores, which gives us an idea of actually how the person is changing. Otherwise, I think it's very difficult to, even for the service really long term, to have a measure which can actually show how people are changing. I mean, you have EQ5D, but really it's not specific to long COVID. It's a very generic measure.
Yeah, I agree, because that's what we're using currently, and the only reason we chose to use the EQ5D because our critical care colleagues within our trust were using it already. And obviously, so for those patients that came through, it was the continuum of that same repeated assessment through their journey, which is why we opted for the EQ5D. But actually, our critical care patients are the minority, not the majority. So actually, we don't need to be using that as a set outcome measure as we anticipated. So obviously, we are keen to try and, like you say, I think at the start we've got a lot of great quality feedback, but we do need that quantitative outcome for the commissioners, and proving our service going forward, that outcome measure we definitely need. And it's something, when we've been sort of, the way we would describe it, it's like we've been building the plane, if we've been flying it, so we've been building the service and growing. A huge priority has gone to sort of the clinical priorities and being very patient facing, but actually probably we haven't kept the data as much as we could have done, and we've probably lost a lot of very valuable data, that, and we've done a lot of good work that we can't prove. But we know that, but we haven't got the data to prove it.
Yeah, absolutely. I mean, that's a shame. And also, I think the ELAROS system is quite good that way, because it can aggregate all the data for you
Yeah,
in terms
absolutely.
of all the kind of the analytics, and we don't need kind of, to kind of manpower to do all the analysis and pull the data together.
And that's what I think. I mean, I can only speak for Blackpool, but that for us is absolutely what we need, because we're the priority is to get the clinical throughput and see patients in clinic, and anything that is time saving for us and is like a platform will be great, because we're not having to so it's there pre-populated, it's got the pre and the post comparison. It'll be really, really helpful for us. Thank you.
Brilliant. Thank you, Helen. There are a couple of questions that have come in on the chat as well. So Carol Langley Johnson at Wiltshire Health and Care says, in relation to the severity phenotypes, are you seeing any relationship to the severity of the initial virus? For example, was the severe category of hospitalised patients?
Yeah, no, we looked at that. No, we looked at the difference, and there wasn't actually a correlation. So it's not to say that the severe phenotypes were the hospitalized ones. So we looked at the difference between hospitalized and non-hospitalized, and we didn't find any correlation. I think it's just the nature of the condition, and it fluctuates. So even non-hospitalized patients can have severe symptoms. So that's what we've seen. And in terms of specific virus, is that the question? Is it the variant? I don't think we've got that data really. That you were referring to the kind of the first wave, the second wave, and the Delta and the Omicron. We've not looked at it that way, but definitely in terms of hospitalized and non-hospitalized, we didn't see that sort of correlation.
Great. Carol, did you want to expand on anything there?
Thank you. No, that was just really helpful to clarify that. That's, I think, the similar picture that we're seeing. And no, I wasn't referring to the subtleties of the different, manifestations of the virus like the Omicron. So that's another question, isn't it, for next year?
Yeah, grand. Then Roman from ELAROS themselves has asked, they're commonly asked about C19-YRS use in children. Would you suggest using the tool for pediatric groups?
Yeah, I mean, I think we've not validated it in kids. I think Manchester Children's Hospital, I don't know if there's anyone here, but they were wanting to use it. I'll probably need to get back to them to see whether they've been using it in their cohort, but they certainly wanted to test it. There's nothing stopping using it, because it's built around symptoms and functional ability, so it should perfectly be okay to apply. Might need a little bit tweaking like any other scale for pediatric population, but the broad principles of measuring those different domains will remain the same. So if anyone here wishes to actually use it in a pediatric population, I think we could look at kind of validating it and maybe seeing whether there's any changes needed in the scale for use in pediatric population. So that should certainly be possible. And that's how all the other scales work as well. So you just need to do a study where you use it in a service and then validate it.
Grand, thank you very much. Did anyone else have any questions? Okay, so I think we're slightly ahead of agenda. We have next up we have Rachel Tarrant and Jenny Davison. if you're already on the line, are you okay to share your slides now?
Yeah, that's fine.
Excellent.
Both, yeah.
Okay, just 5 minutes ahead. But yeah, we'll move on if that's okay. So yeah, we should be able to share now.
Okay, can you see that okay?
We can do, yes. Yeah.
So I'm Jenny and I'm presenting alongside Rachel today. We're both physios by background and we work as the pathway coordinators and clinical leads for the Leeds Long COVID service. So I'm going to talk through a little bit about how Leeds came to where we are now, and then Rachel's going to go more into detail about how we particularly use the C19-YRS within our team. Manoj touched a little bit about what happened. So within Leeds, because of the research that was done so early, we managed to get a really integrated rehab pathway set up quite quickly. And we use primary care, the 2 trusts that are within Leeds, University of Leeds, Leeds City Council and the CCG. So it was very multi-organisational right from the beginning. We decided in Leeds to do the rehabilitation alongside the assessment right from the beginning as well. So we had a team that kept all the rehab in-house. So what happened was the evidence review that Manoj talked about a moment ago with the service evaluation that was looking at the symptoms of people post-discharge from hospital. And then they got together between July and August 2020, all the people that you can see in the hoops there, to put together a proposal for what the team might look like and what the needs might be. And then in September, me and Rachel were seconded from our roles. So I came from the rehab side and Rachel came from the acute side and the respiratory service in to set the team up for the rehabilitation and assessment. And we've just been going in a PDSA model ever since with quarterly evaluations. So we accept people that have continued symptoms for more than 12 weeks, not explained by an alternative diagnosis. And they put together some guidance for GPs around how they can rule out alternative guidance and pre-referral investigations, such as chest x-rays, sit-to-stand tests for desaturating patients, etc. And we also looked at what the hospital pathway might be. And what we found was that most people coming out of hospital, if they needed rehabilitation, were referred to either the community rehab team or the respiratory community team if they had oxygen needs. And then they have a referral pathway into us at 12 weeks if problems persist. The other things that we worked with was alongside with our GPs looking at signposting. So when we first went live, there was just phase 1 of your COVID recovery. So making sure that GPs were signposting people towards the self-management. And also what was developed was a booklet, so the COVID-19 rehab booklet that was given to patients in hospital or could be given out by GPs. And that's the first in a series of booklets now. We now have one specifically targeted around long COVID. So our model is the majority of referrals are primary care referrals, like another colleague was saying earlier on, and then we do get some that have come out of hospital via our community services. Within our team, we've got myself and Rachel as the coordinators, we've got physios, OTs, dietitians, rehab assistants, clinical psychologists, CBT/EDMR therapist. We've just recruited a GP to sit within the team as well, and we've got admin and project support, and alongside the research that's inbuilt in the team as well, which Manoj oversees. We have a weekly NDT, virtual NDT, and the consultants we went for were rehabilitation medicine, respiratory medicine and cardiology, and that seems to be working really nicely. We've also set up a lot of partnership working. We've got Leeds Active that are piloting a programme for how to increase activity and exercise. So it's more for people that are coming out the other end, so they've had the fatigue management advice, etc., and are now able to build up a little bit more. We've got specific long COVID singing for breathing, and we're piloting peer support hubs across the city as well. And the one thing that we kind of hope from the legacy that is long COVID. We're, you know, being optimistic here, it's going to finish at some point and people will all be discharged. But hopefully we want to see this as a long-term condition model for future management of long-term conditions. I'm just going to pass to Rachel.
Thank you. So just the amount of changes that have happened, not I'm sure in all your services as well as ours, but we started as very much as a home visit model of care in the community with 8.8 AHPs. Obviously the service need and demand was very much unknown at that point in September when we started with, you know, we didn't know the full etiology and rehab needs. It was very low profile, obviously, and there was no information resources or information. We were using triage at that point from September when we went live. We started using the C19-YRS on the 0 to 10 scale that Manoj has shown you, and we were doing that on email, paper, and on the telephone, depending on what the patient's needs were. So now we've very much changed to a hybrid model. We're face-to-face in clinics, we will do home visits, and we do a lot of virtual work with patients. We are a team of around 30 now with admin and ops support. We've developed a 10-week virtual symptoms course. We're obviously supporting the locomotion project, and as Jenny's mentioned, we've developed some booklets along the way as well. In terms of the C19-YRS though, we now do that predominantly via the app. So the average age of our patient, around 48, is obviously pretty digital savvy and does have smartphones and access to these sorts of things. However, we obviously don't want to rule out those older patients or the patients that aren't as haven't got those digital skills. So we do offer email versions, or we pop it in the post to them and they can do a paper version, or we complete it on the phone with them. We have members of staff that can do that if that is required, if brain fog symptoms or neurological symptoms won't allow them to do that in the usual ways. We get those assessments done. So on the app, we will ask them to do the C19-YRS alongside some other outcome measures of choice, EQ5D, MRC, and modified fatigue impact scale we use at the moment as standard. And then if there's a gap between triage and then seeing the first clinician in clinic, then we will ask them to complete those again, because at the moment with the current state and some weights that we have, they're not always seen as timely. Then we review it again after the 10-week virtual course, so we get some outcomes after the course to see where patients are at, and that's done face-to-face in clinic again. But we ask patients to complete them if they can before coming to that appointment, so we've got all that data to use within the appointment to focus goals and then identify ongoing needs. And at that point, if they're continuing to be seen within the service, then we look at reviewing these every 3 months and then on discharge as well to collect that data. So really the benefits that we've found of using the C19-YRS in clinical practice is that it's a very in-depth screening tool, as I'm sure a lot of you that are already using it will know, and it does cover the whole range of long COVID symptoms, especially the new modified version, which has now got post-exertional symptom exacerbation in there as well. It's obviously been developed and piloted within a long COVID service, so it's been used by patients. We've had a patient user group give feedback on this. We've had clinicians feedback and obviously research involvement as well to validate it. Patients report that it captures the wide range of symptoms, which really validates their experience of living with long COVID, which I think is really important to know. And they do realise that it is quite lengthy, but actually, because it's so thorough, they like to do it because they feel that it captures everything that they need to tell us and inform us about. It's really good within that triage call because it formulates a structure to that conversation, which can often be very lengthy and there's a lot to discuss. So, and that's really vital that we're efficient with that time and going through that information with them. And it makes for a really meaningful conversation where patients really feel listened to and their experiences are validated. It also does identify symptoms for us that haven't been flagged to the GP. So sometimes patients won't have told the GP all the information that they tell us, so therefore we can flag that with GPs for further investigation or if they need referral on at that point as well. And it also allows us to identify the first port of call professionals within our team that really need to be supporting the patient, so we can make onward referrals within our team obviously, but also we can refer on to different specialities external to the team if required as well. Also, obviously, it is the only validated outcome measure within long COVID currently, so it is really vital to demonstrate patient progress and evaluate the effectiveness of our interventions as a service. So key lessons learnt really are obviously the care coordination that is involved within these patients, and you'll all know that, but the triage and the C19-YRS is really critical to that. Patients do need longer appointment time, so we offer an hour appointments for triage, so we can really look in depth at that C19-YRS. Consultant, medical support, and the skill mix of the team is really vital as well, the skills that are required to treat these patients. And obviously it's already been mentioned about research, vocational rehab needs, and sort of partnership working to help longer term management. So the next steps really for us as a service and sort of working alongside ELAROS are developing some self-management material to sit alongside all these outcome measures that it's collecting at the moment. So we're working alongside ELAROS to find the best resources out there, and I'm sure they'll want to hear from you all on the call if you're using resources that you feel patients find really useful, so we can factor that in and find the best things. We've also in conversations with ELAROS and our BI team at LCH in terms of reporting from the app and how that can be linked with our clinical systems as well to support that data capture and evaluation at a clinical level. We also really want to evaluate the C19-YRS scores that are coming through and look at these symptom severity, functional impact and overall health scores, and really whether this can predict not just the phenotype that Manoj demonstrated to you in some graphs earlier, but also those phenotypes then, can they be linked with their scores to the likely interventions that are required, so we can forecast service delivery and staff demand within the staff pool as well and workforce. And also looking at these numbers and scores, can we predict likelihood of recovery versus long-term condition as well? So that obviously will be really useful in the longer term. That is the end of us.
Brilliant. Thank you very much, Rachel and Jenny. I think that's really useful to see how you've implemented the system and how you're using that within the pathway. Before anybody else has any questions, I just wondered how quickly you've implemented that and how quickly you would say any other trusts who aren't currently using the system could implement the same system into their pathways.
In terms of the app, do you mean, Sophie?
Yes, yeah.
So the app, the training guides are really helpful. So the training guides, and ELAROS did some bespoke training for the team as well. So there's a training need around your admin that might be, for example, uploading the patients on and getting them set up. And then there'll be a training need for anybody that's exporting, but it is quite simple to export data that you want. We use System 1 as our clinical system, so we can export all the outcome measures, the results, there's nice graphs that show patients their development as well. We can export that and just upload it on our record attachments. So it's not complicated. The other thing we've chosen to do as a service is to disable it when they are discharged, which is something that I'd get you to consider as a service, because there are questions on there around low mood, etc. And, you know, if you are having thoughts of self-harm, etc. And we didn't want patients to think after they've been discharged that that is still being looked at by a clinical team. So there's an option to disable, so they can still access it and look at what they've put in, but they can't put new results into there. There's an argument to say that for patients, you could just explain that so that then they can carry on seeing their graphs. It's just what we chose to do at Leeds, but it's not difficult to work with at all.
And it's quick setup, isn't it? If you decide you want to go ahead with it, ELAROS were really efficient. It's really quick. I just actually forgot to mention something on the last slide that I'd like to come back on in terms of you talking about the children's C19-YRS and obviously how important that work is. Because actually we're starting to see patients transition from paediatrics into our service now, and if we've got the same scale and use, that will be really efficient and like really helpful in using and making that transition a lot more smoother, rather than starting to use a whole host of different outcomes that they're not used to. So I think that's really important work.
Grand, thank you. No, I think that's a really useful point. There was also a question in the chat around if you're able to expand on the peer support hubs that you have in place.
So they're being piloted soon. So we're happy to pick up a conversation or pass on my details if you want to contact me directly about that. But we've worked with Leeds City Council with this. So we're doing 2 pilot areas within Leeds in 2 postcode areas where we've had lots of patient user feedback involved in this as well, to see what they would like to see within the peer support. What would that look like? What does that intervention look like? And it's going to be run external to the service. So once we've piloted and captured that data, which again we've said they can use the C19-YRS for this, it doesn't need to be used just within a clinical system. So you know, that could be support sort of these external partnerships that these long COVID patients are sitting within. Then we're hoping the aim is to expand then these peer support hubs in every area of the city, because we know these patients obviously are fatigued. They struggle we're a large catchment area in Leeds, you know, in terms of travel from one side of the city to the other. They need to be in their specific localities for them to develop that sort of support.
Okay, excellent.
Kiboshed because of Omicron, so they're back now. So we're hoping that we get some good feedback from them now that they're starting again.
Yeah,
excellent. Thank you. So I think that query is coming from Rose Maloney and from Annabelle Jordan, who we can pop you in contact with afterwards.
Fine. Yeah, absolutely. Yeah,
pop my email address in the chat.
The other peer support, we do is not the external hubs. We have on the 10-week virtual course, we have like a presentation that's about 20 minutes and clinicians on that call. And then we really do support peer conversation for the remainder of that hour. And that's fed back really well from patients as well. So it's a different sort of peer support because it is facilitated by a clinician, but that's quite valuable. So if you run anything like that, we've had really good feedback on that patients enjoy that feeling of not being alone, and they share quite a lot of what's helped them, which, you know, as clinicians we love to hear what's helping people. If they've tried something different and it's helping, then it's quite nice to be on them conversations as well.
Yeah, okay, brilliant. There's also been a query as well around if you've had any pushback from patients about downloading the app.
So if they can't download the app for whatever reason, whether that's just patient choice or whether they haven't got the digital skills, then yeah, we have got patients that are on a variety of filling this in, completing this in a variety of ways. So yeah, we will either do it via post or email them, or we'll complete it on the phone with them. It's up to them.
And I believe you do it via the web as well, rather than having the app. I mean, Roman might know more about that. Manoj, pretty sure they don't have to download it because that might be barrier to people with limited memory.
A lot of people won't download it. A lot of people will say, "Oh, I haven't got enough data on my phone to keep it," but they will log in via the web and they'll fill it in that way.
No, that's useful so that people have those options as well, particularly with digital inequalities aspects and so on there. That's useful to know. And there's another query around from the same person around if you collect other outcome measures alongside C19-YRS digitally.
So we have been at the moment, haven't we, Jenny? Because obviously we were waiting for the validation study to come through, and you know, this is all very new on the app at the moment for us as well. Even though we have been going a little while. So yeah, so we do EQ5D, MRC, and MFIS, and the GAD7 and the PHQ9 as well. But we are hoping to move just to the one measure, and then we won't need to be collecting all these other measures because it is all encompassed in the one measure, and that's the way forward. That's the way we want to go.
Yeah, I just wanted to quickly add there that there's some interesting work actually coming from Italy. Now, this is completely independent of us. So what they did is they used a lot of these other measures to kind of measure these individual symptoms, and they also use the C19-YRS. And what they found is, so these different scales, so the GAD, the PHQ, and MRC, and other scales as a host of measures. And what they looked at is correlation between that, the total score on that, versus the single question item of the C19-YRS. And they found that actually the correlation is quite good. So their conclusion is, well, rather than use all these measures, just use one measure. So that's yet to be published, but it's good to see that it's actually coming from somebody independent. It's not us, and it's coming from Italy. So just want to add that.
Oh, thank you. That'll be a really useful piece of research to consult with. Sorry, Rachel, were you just about to say something?
No, I was just going to say, as soon as we can go to the one measure, the better. That's the way we want to go.
Excellent. Well, thank you very much for your presentation there. I think that was really insightful. I'll hand over now to Joe McGee from Airedale NHS Foundation Trust to go over your presentation. Are you okay to share your slides there, Jeremy?
Yeah, thank you for that, Sophie. I'll just bring my slides up and hopefully you can all.
It looks like they're coming up. There we go.
Okay, so hopefully you can all see that. Okay.
We can do. Yes.
So,
yeah, thank you.
Hi, my name's Jez. I've sort of had, it's everything I'm going to say. There's a little bits been touched on so far, but that's sort of a sign of how quite close we've been working up in this area. So it's been really good to work really closely with Manoj to start with, and then with Rachel, Jenny as well throughout this. So it's been really nice to have very good neighbours on this work. So my name's Jez. I'm a physio qualified, advanced practitioner qualified, and used to work in community services, and then got really into long COVID work right from the start. And we'll go through a few more details later on. I work for Airedale NHS Foundation Trust, as well as, which is now developed into the Bradford Districts and Craven Long COVID Pathway, as part of the Act as One project, which is an umbrella project over 3 different trusts. Airedale is an acute and a community trust, and then there's Bradford that's got both an acute and a separate community trust. So we sort of work as an umbrella over all 3 trusts. So asked by ELAROS to present today to give a slightly different perspective, more from a setup speed, I think, from not having the significant funding right at the start from the CCG point of view. So we've got our funding as it's come through from NHS England, whereas Leeds did really well in the first place to get that funding right at the start, which is helped from the start. So yeah, we were sort of slightly jealous neighbours to start with, but it's been really nice to share that, and then we've got everything pretty much in place now, which is brilliant. So just as a bit of a background in where we are, so we're covered the Bradford area, which is this area here. You can't see Bradford because that's where pretty much all these dots are all our patients that we have. So pretty much most of our patients are in the Bradford area, a little bit of a hub around the Keighley area, and then we do cover all of the Craven area, so the Yorkshire Dales, but very few patients at this minute referred from that area. And this is the ethnicity breakdown as well, but we can go into that a bit more detail later on. So I was going to work backwards a little bit and just show you where we're at now, and then restart again and say where we've got to. So this is where we're at now. We've got a pathway in terms of an assessment and coordination aspect, and then also the rehabilitation aspect. So we've been fighting for this rehabilitation aspect right from the start, but just not had the funding to set that up. So we got this assessment started fairly early on. So we had our first patients coming in July 21, so about probably 6 months, maybe 9 months past Leeds. And yeah, at the moment, so the patient gets referred in, they coordinate in terms of what put onto the systems. They get sent out in terms of the information for the C19-YRS app, which we'll go into a bit more detail, but they also at the same time get offered shared harmonies, which is a little bit similar to the singing and breathing group from Leeds. And that's again another local VCS group. And then we're looking at moving the 7-week primary care wellbeing course, which is essentially looking at the various key areas of COVID, long COVID, and discussing that with the patients, and that's psychology led throughout that. So I'll come back to this slide a bit later, but just to give you an idea of where we are at the moment. So how have we got here? ELAROS are really keen for me to show how we've done each step to start with. So I suppose from us, we've always seen sort of nearby other people progressing really quickly, but we understand obviously there's other areas that haven't had that luxury and haven't been able to do that quite as quickly. So part of doing this talk is to try and support those people who are maybe at an earlier point on this pathway, and more than happy to support any conversation going forward. So it's been lots of hard work, talking to, assessing patients. So I think that's been one of the biggest things for myself, but also for the staff that have now joined the team as well. The best way to learn is to speak to the patients. As much as we plan, as much as we try and read and everything else, it's really, until you speak to the patients and get to see the individuality of every patient, it's really difficult to manage this patient group. Shared learning, as I mentioned already quite a few times with Leeds and other trusts around the country. various courses through the CSP and everything else. It's been really good to share learning and things like Microsoft Teams and all the sort of webinars and everything else that's allowed this virtual world to be a lot more accessible going forwards. In terms of prioritisation has been massive. So I think there was a question earlier in terms of progression wise and everything else. So we've had 1.5 full-time equivalent staff from July to, well, from May really when we started to December. So that's been myself as a part-time secondment, another part-time secondment into the coordinator to make 1 whole-time equivalent, and then a half-time admin role. So that's what we've formed this pathway with and completed the assessment side. We have been very lucky. We've had an MDT which has included rehabilitation consultant, respiratory consultant, cardiology consultant that I've run once a week, and psychologists in there. But in terms of actually funding purely for the service, this has been the input that we've had. It's been very much an Access One approach, so we've had loads of support from lots of different people across healthcare, outside of healthcare and everything else, which has been really good. And the funding, as I mentioned already, when the funding has come through, that's allowed us to make the next step, and up to that point it's been prioritising what's best. And it's been really difficult to work out that prioritisation between seeing a patient caseload building up and waiting list building up versus trying to get a rehabilitation team set up, knowing that once that is set up, then that will support that caseload at the start. So it's been really difficult trying to sort of balance that. In terms of the main part for us was making sure that we got a remote solution for digital service. 1, we'd never really had a base across the 3 areas. 2, covering such a wide area, it wouldn't have really ever worked with a base. So it was always going to be a virtual or a home-based setup, which we then went to see patients from their own house or into clinics rather than a base where we went out from. From an Airedale point of view, we've been paper-light for quite a few years now. There was a big Axe the Facts thing a number of years ago, and the acute and the community all together. So it really helped us, and everyone's on system one patient record. So that, from an Airedale point of view, was really good. And when we moved, as we'll come to later, to working with Bradford as well, then that was bringing in more challenges with that because it wasn't the case. And lots of listening and learning. So anytime you get to speak to anyone, just have a little listen. So this was the slide that I think was the sort of the key bit in terms of progression wise. So just trying to say where we were, and I've tried to link it with the waves in terms of so the first wave, second wave, third wave of COVID. And then these are lockdowns, just to give you a little bit of an idea, because I was doing this last night and you forget where you've been and how quickly things changed. So right back to the start, April 2020, we had the first Airedale long COVID rehab meeting to try and work out how we were going to identify this patient group that was being discharged from hospital. There wasn't that much of the community talk at that time, and how we were going to manage them, how we were going to work out what services we need and what sort of services they need and which professions and everything else. So the first draft of the sort of long COVID screening tool is a way to use that to speak to patients on the phone. And then from there, we did the first telephone screening of patients discharged from hospital post-COVID-19. I haven't included all the app stuff and development and everything else, because I knew sort of Manoj would be doing that anyway. But it was really good at this point to be sort of working with Leeds, and the size and the accessibility from the research point of view, everything else was brilliant, and something that from an Airedale point of view we've really benefited from, which is really good. So from September 20, we completed our Airedale first wave post-COVID review. So a little bit similar to Leeds. It wasn't published at the time. It was something that we used to present to the board of directors and try and sort of create an urgency really for the need to support this patient group. And I'll show you a little bit more from the staff feedback, which was quite interesting at that point. The funding then got announced for the post-COVID syndrome assessment clinics in November. So at that point, we then decided to go to a place level, so working across 3 trusts rather than a single trust and trying to divide it again. And that was really important for where we've come to. So once we joined up, we're about 6/7 the size of Leeds, I think, in terms of the population. So it made it a much bigger group. And especially when we look at the idea that Airedale patients in terms of community-wise is actually quite low compared to the amount of Bradford patients we've had so far. From the funding point of view, that was actually released then in February. So by the time we actually got access to that was February. And that was when I sort of joined in May as an official role, although I was already heavily involved in it. And also then Carol as a part-time admin, and Jenny at the time as the other half of myself, coordinator. So from then the biggest thing in terms of for us was always that with 1.5 staff, how do you set up a service where we need to screen so many patients? And the app was sort of developing. So I think it was probably about November time when ELAROS started working with the group that we had with Manoj and Leeds. And from that point of view, we sort of knew that that was getting closer and closer and closer to ready. So it was really key for us to get that in place. Getting the information governance from anything is really difficult, and getting, especially from an IT service as well. So when it comes to an app, in terms of holding patient data and everything else, if anyone is thinking about using the app, that's the first place to go straight to your information governance team and your IT service, and link that up and create meetings and get the conversation going, because you've got to really work on that side of it. Once that was in place, the rest of it has just been easy, but you've got to get that in place first. So I definitely recommend that as the first point. We had our first patients accepted onto the caseload, so we opened up to referrals in July 21, and we had confirmation just after that of the national rehabilitation funding was coming through. So that was really good, so we could start to focus on this idea that we weren't just running our own service, we were actually running a service that we could offer a rehab unit to it rather than referring out. So we agreed, so at that point then we had to do a case study together to what we actually wanted to request the money for. So we put all the numbers of staff we wanted to put forward, and we agreed use of national rehabilitation funding with the NHS England, so that allowed us to gain that funding then from that point of view. In terms of from then interviews with the rehab team in October, and as of January we now have 13 new team members, so we've got a total of 16 now, which has been absolutely amazing for this last few weeks to have all this really good staff in post. So yeah, so that's a little bit of a summary. In terms of the study that we did, the data was pretty much exactly the same as that Leeds have done, which you've seen already. But I thought it was just interesting, this was some of the feedback from the staff that were doing it. So it's taken, every staff member was ringing a patient, having the conversation. These were all hospital discharge that we'd highlighted as needed to be called. Excuse me. So one of the first things was, what were the benefits of being part of this programme? And the patients were really enjoying having these conversations and found it really useful and grateful for the call. But I think the key bit is the other comments bit. So one of the comments was that this has been a very time-consuming project. It's been difficult for teams to keep up with their own workload and find the time to contact these patients. And they devoted many hours. So we actually ended up employing someone for 6 months to ring all the patients that were discharged in the first wave from Airedale. It took all that 6 months to do that, so it was a huge amount of work and a lot of time to do that, and that was ringing up and going through every question with every patient, and that was through the original version that we had. So what do we do now? So at the moment now, so the process of using the C19-YRS, the referral gets put in, our admin Carol will email out to every patient that gets referred in an introductory email, and then once we're ready, due to the delay on the pathway, then she'll send out, or she'll register them to the C19-YRS, and then she'll ring the patient to speak to them at that point. Not all the patients answer straight away, but she'll put them on for the next day, and she generally gets hold of them in the first or second day. In terms of when she rings them, she will then email them the username. So we had an information governance discussion that we would send them the username and the password in 2 different things, because it actually will create NHS number, I think, is on there, and a few other bits of details, or certainly the patient's details are on that area. So they will get an email with the username and a text sent out to them with the password that they have to access the app. Once they've done that, we ask them to reply via email once they've completed the app, which they do. And the team just check weekly to make sure there's no one that's completed that hasn't emailed. Just you can do a search on the app itself or on the web app that we use. And then we ask them follow up with we send them a text after 6 weeks to ask them to repeat it, to repeat the C19-YRS at that point. So one of the things that I was talking about, Rona, so we've had 96% of patients have completed the app or the web app without team support, and the other 4% of patients have been supported through Carol, going through the questionnaire with the patient and completing the app at this end. So it has been really a large amount of patients have actually managed to complete it independently, which has been brilliant. But yeah, as Manoj has mentioned, there's alternative ways if needed. So then we go to this is our coordinator assessment. So it's pretty much the app itself, but just a broken down version, so we can ask more details on each patient. So we basically just run through this with the patients to really get a more in-depth questions on that, which is really useful. And we always focus off with what's your COVID experience been and how have you been since, and that normally gets a good spiel from the patient in terms of how they've been, and we get a load of information from there. in terms of financial wise, we ask a lot about work side as well and things like that, and any financial support they might need. So going back to the pathway, again, very similar to Leeds as we've gone through really, and we've just sort of added our own little bits as we've gone. It's been quite nice to have that, to see what's been progressed and then do it our way, which works with our area, but it is very similar. And a lot of the things, just different names within our area. So once they've been assessed, they get moved into this area, into the rehab now. We've had the virtual MDT running for the last 6 months, and that's as we mentioned with the different consultants in. We're also going to have a rehab MDT as well, which is not going to involve the medical side. That's more to look at the rehab side. We're going to have a therapy-led objective clinic, which we're really excited to have our first 2 clinics next Tuesday, and that will be where we're going to bring 10, but 5 to start with, 5 patients in one go. They'll gain a peer support circle, which will be run by the psychology assistants or the mental health nurse. And within that, that will help to start a conversation between the groups and to monitor for any concerning things that need to be supported, but also to allow them to gain that peer support and develop social interaction with other people with the same situation. Within that as well, we'll take people out and do breathing pattern disorders while the physio in their assessment. So that we're looking at the breathing pattern. We'll have an OT in there to look at early input from the fatigue diary and other fatigue management side. And then we'll have some therapy assistants working on sit-to-stand test. All these have been in a lean test as well in terms of looking at postural hypertension and POTS. So we're looking at including that as well. And then also doing a full news score and so the 1 minute sit-stand test from there. So that gives a really good idea of, one, from a subjective point of view virtually, and then an objective point of view face-to-face of where this patient's at and what we need to do going forwards. And then we'll have a number of different areas that we're going to focus on in terms of whether one thing that we're really looking at the moment, and again, if anyone's got any ideas going forward, that brilliant, will be how we manage all these different symptoms in one go. So we've got the 7-week course, which has been published. That's going to go through each area in fairly broad ways, but it's just going to be trying to get ahead of ourselves and try and bombard the patients with everything at one go, which I think is one area. But yeah, looking at lots of virtual face-to-face group sessions, one-to-one, both rehab and education. And then we have a lot of support outside of the pathway from the primary care wellbeing team, the voluntary and community services, my wellbeing college, which is like the where you're getting a lot of the different areas, IPATs, and then the BEEP service as well, which is similar to what Jenny was mentioning, I think, in terms of in Leeds, but in terms of looking at that deconditioning group with patients when we've got past that initial phase, and then looking at almost potentially through discharge going forwards. So that is our pathway. In terms of demographics, very similar in terms of age breakdown, mostly working age. Got 436 patients on the pathway referred so far. I think there's 380 active on the pathway currently. We've got very much the gender split that you're seeing everywhere else in terms of 69% female to male. In terms of the deprivation scale, so very much in that lower in the higher deprived areas, so 1, 2 and 3 area. And from the ethnicity, which is probably where we're slightly different, I think, than the national average, 50% white British referred so far and 35% Asian or Asian British, but that probably reflects our communities as well, particularly around the Bradford area. So we've got loads of good work that's been done so far. We've got a post-COVID, a long COVID booklet that we set up, and then that's now been developed into an easier read guide with lots of images and less words, as well as having the BSL versions, which have just been released this week or last week, which are all on YouTube now, for all the different aspects of the group as well, and audio versions as well for people from an audio point of view without the literature. And we've also done a 40-minute presentation for GPs within the area to watch in terms of a bit about long COVID, but also in terms of about the local service, just to support them as well. So the future, developing the rehabilitation team, is a really exciting moment, but lots of work to do from that point of view. Reviewing development time versus patient time, so hopefully moving more towards more patient time and less of the development side, but that will obviously progress as well. Integrating the C19-YRS digital solution system 1, which will be something that I think ELAROS are looking at going forwards, and that would make a massive difference to us. That would be the next big time saver. So it's been really good to manage with a half-time admin to do the whole side of that. But if we then didn't have to download it and move it on system 1 after, that would be the next big step. So if it just automatically populated, that would be absolutely brilliant. So we've been talking to Bowman about that quite a bit. Student clinics, so we're looking at potentially doing a student clinic at Bradford University as part of this objective-led therapy clinic, which would be interesting. And yeah, continue shared learning both local, regionally and nationally. more data reviews, and as I said, there's a study that's been published from the primary care wellbeing team on 7-week long COVID course that we offer, and also looking at further research as well. So thank you.
Brilliant, thank you very much, George. So just getting some feedback. This sounds really weird. I think that's given a really good overview together with the Leeds pathway there as well. I think there were a number of queries raised in the chat through the presentation, most of which I think were answered. I just wondered if anyone wanted to expand on queries that they raised in the chat. I can see the last query there as well around the languages that are available. I'm not sure, Manoj or Roman, if you wanted to expand on the language capabilities as well.
So, I mean, as I just responded, Sophie, I mean, it's available in many languages, but we don't have the copies of them because they get in touch and we just say, yes, I mean, we authorize them to translate. So we don't have the copies yet, but along with ELAROS, we are trying to actually chase them and collect a kind of a database of all the translated languages. Most of the European languages, it has been translated, and I think some of the Asian languages as well. But in terms of sort of relevance to UK, Punjabi, Urdu, it's not been translated in those languages. It's mainly, I think, French, Italian, German, those kind of translations has been done. So I don't know whether that will be relevant to UK population anyway. So yeah, I mean, open to that as well. If people want to commission or translate it in other languages, it's absolutely okay with us.
Yeah, we do have a local group that are looking at supporting us to do that, particularly in Bradford area, particularly on Punjabi and Urdu. So we're looking into that.
Oh, great.
Great. No, that's good to know. I guess that will be really applicable in a lot of areas as well. Helen Duggan, I can see you have your hand up as well.
Sorry, it was probably just a question for possibly all of you really. Within the ELAROS platform, is there an outcome that relates to patients' goals? Because obviously for us as therapists, we're very driven by a patient's therapeutic plan being based on the patient's goals rather than it being driven by the Yorkshire screening tool or a fatigue measure. Is there anything within ELAROS that actually is patient goal specific? So again, we can measure that against the person's goal.
So as far as I'm aware, there's no such specific measure. Are you referring to scales like goal attainment scale?
Yeah. Because as therapists, that's obviously we're very much guided by, obviously for us, what the person wants to achieve. It might be hard to measure, but if that person's goal is to get back fishing or something, whatever is important to them, is that built in ELAROS? Because that's actually for me is an important measure for the patient. So it isn't just focused on the symptoms, it's about their person's quality of life and that person's personal goals.
I think that's definitely something to pick up with
Helen. Can I just come in? Actually?
Thank you. Thanks,
Helen. You're right. It isn't something that's on ELAROS, but that's something I'm sure if there's a tool you're wanting, because they've been very accommodating for us in Leeds. We've asked for things and they've just popped it on for us. But in Leeds, just in terms of patient goals, I absolutely agree with you. We've developed a passport that sits along the patient journey. So they actually can document all these outcome measures in the passport if they want to, and it links to our virtual course. So it has like homework and tips and stuff that they're working on and their goals written in it, and we review that every time we see them. So that's kind of what we're doing on that sort of level. But yeah, you're right. It would be really good to have something digitalised as well.
Absolutely, because I think that's for us as obviously we're as therapists, we're pushed to very much making it functional, making it relevant, making it meaningful. And actually for a person, it isn't just about that symptom measurement. It's about their quality of life and that self-attainment, self-achievement, which is very goal-driven. And for me, having a goal orientated outcome measure would be really helpful to have within ELAROS.
Yeah.
Thank you. Sorry. Thank you.
Fine.
Okay. And thank you. There's a question that's come up from Claire Gibbons as well as Salford CCG. So for those services not using C19-YRS to measure ESS symptoms, which alternative tools are you using? So if there's anybody else on the call who wants to provide an answer there, or any insight as to what you're using, that would be quite useful there.
There was just to answer that, there was a document that's been sent around trying to collate all the different outcome measures that have been used in the different services this week. And I think just from looking at that, the services that aren't using it are using just a wide spectrum of the key ones for each different area. I think I didn't see one that was a broad spectrum.
It's a Newcastle scale, isn't there? I think as well, a screening tool that Newcastle developed. I've actually not seen it before, but I'm aware of that as well, that some services have been using.
Mm-hmm.
And certainly in Melissa's service in UCL, they use something like, which is similar to the C19-YRS, but hasn't got kind of a name. It's a list of kind of symptoms with their grades. It's not kind of in a scale format.
Mm-hmm.
Yeah, EQ5D people have posted there. Yeah, EQ5D and post-COVID functional scale are some of the other measures being used. Yeah.
Mm-hmm. Thank you, Manoj. Tina?
We just used in Stockport, we adapted the Yorkshire screening scale, the original one, so that we could create a template for our EMIS, so we didn't have to transport from paper to electronic. So it's a cobbled together one from that original. So, well, obviously we're looking for the ELAROS to smarten that up now.
Tina, we did that in Leeds, and then we've gone back because now we can't use it as an outcome measure. So I adapted it that much because at that time it was a screening tool, and I thought, oh, I'm going to get the extra bits in there that I wanted as a service. And then it was like, oh, now it's going to be an outcome measure. I'm going to go back and I'm going to use this one, and I'm going to put them other bits somewhere else. Yeah,
I mean, I'd just like to say we're quite open with any kind of suggestions people have, because the scale is kind of evolving. We've modified it. So if there's any suggestions people have, please do send suggestions and we'll take it to our PPI group. No problem with that.
Brilliant. Thank you, everyone. So I guess if we hand over to Roman from ELAROS themselves at the moment to provide an overview of the system. Roman, have you got your screen set up and everything there? Yeah, excellent. Like clockwork.
Thank you very much, and thank you to all the speakers today. It's been brilliant. I suppose given everything that we've seen today, I did have some slides prepared, but I'm happy to kind of send as an attachment to anyone who wants to follow up with us. But I think it'd be best to deliver a quick demonstration rather than kind of continue with another presentation or PowerPoint. So the digital platform comes in two parts. There's a clinical web portal, and this is intended for service-based staff, clinical and non-clinical. Anyone who wishes to have an account can have an account at a particular service. And the second part is a patient-facing app, and that patient-facing app can be accessed either on mobile, accessible on Android or on iOS independently at home. Alternatively, for those patients who don't have a mobile phone, who opt into not using a mobile phone or who can't use a mobile phone, they do have a web-based alternative. So I think somebody in the chat mentioned, kind of touched upon digital inclusion and accessibility, and we've got ways around this to kind of tackle this. So if we log into the web portal here, this is essentially kind of where every member of staff can have an account, as I've mentioned. This is where you would go to view all your kind of patient lists, to review assessments, to add patients to the portal, and ultimately to kind of export some of those results and put them into System 1, EMIS, RIA, etc. So what you see here is a demo center with demo patients. As you start to build up a patient list, you can search for certain patients using a name or searching by NHS number. You can filter kind of certain patient groups separately, such as ethnic groups, genders, age group, centre and locality. I'll describe that a little bit in a second. But you can see some of the patients are highlighted in blue. I've got a little bit of feedback. Essentially, these patients who are highlighted in blue, a member of staff can indicate or highlight them as an NHS worker or a care worker who is a patient in the service. So we've added this feature just as an optional feature to kind of support one of the long COVID priorities, just to rehabilitate those patients that are members of staff or care workers. But the key kind of next step, or the first step, to get the patients onto the system. This requires a member of staff, usually an admin member of staff, to kind of add them to the portal. And this requires 4 key bits of information, and that's first and last name, date of birth, NHS number, and gender. And you've got the option here to confirm whether or not the patient is a member of NHS staff or a care worker. Once you've filled in those fields, you'll then need to assign them to a centre, and most centres usually have one virtual centre, and that's just the name of your hub. So in Leeds' case, it's Leeds Community Rehabilitation Pathway, I believe. So essentially, once you've assigned a patient to that centre, you can then assign them to a locality. And the term locality is just used to represent a city, town, borough, or region which your service is servicing. So in Leeds' case, they have one locality, and that's Leeds, whereas in Airedale's case, that is, I think they've got Airedale, Craven, and Bradford. The example here is for Pennine Acute NHS Trust. So they've got one long COVID service, and they're servicing patients from across Bury, Oldham, and Rochdale. Again, as I say, this is optional. So once you've assigned them to a locality, you can separate out the patient list. You can kind of, I suppose, kind of evaluate those results kind of separately by kind of filtering the patients by locality here. So that can facilitate any kind of service evaluations, any reporting to NHS improvement, and things like that. Once you've saved that patient profile, those patient details, this generates a brand new kind of patient profile with all these tabs, which are initially empty, but these are automatically populated after the first C19-YRS assessment is completed. So we've got a tab on personal information, which just covers some demographics factors such as height, weight, smoker status, which can change over time, medical history. We've also got a COVID data tab, which covers things like the date they first started experiencing symptoms, whether or not they had a swab test or antibody test, what was the result, the date of those tests, and number of days in hospital or intensive care, and whether or not they've had any medical problems which required hospital admission since their infection. We've got a tab here just on assessment list. So this is essentially where a member of staff would go to kind of review any kind of completed assessments, look at the individual reports and export them. But essentially, once a patient's first been kind of registered to the portal, you do have the option of kind of customizing what PROMs the patient would see. So these can be configured on a per patient basis if you want to add or offer a PROM for one specific patient. But it can also be kind of configured just to kind of decide which PROMs you always want to give all new patients. So we have a list of these PROMs at the minute. So we've got the C19-YRS, we've got the modified C19-YRS here, we've got the EQ5D, fast fatigue, etc. And essentially how you might use this. So if I give the example of Provide Essex, it's just their policy where they would like all their patients to complete the C19-YRS, the EQ5D, the GAD7 and the PHQ9 after being referred. Rachel and Jenny have kind of mentioned some different PROMs there that they use locally. I think there's been a lot of questions about kind of other PROMs which can be added to the system. Essentially, we are open to adding different PROMs. There's obviously the question or argument on whether you should use them or which ones are kind of suitable or validated. But things like the goal attainment scale can certainly look at. It's just a case of working out whether or not there is a license fee in order for us to kind of embed it into the system. So I'll come back to this page once a couple of assessments have been completed. But the key kind of information to remember, essentially once a patient is being added to the system, is that this generates a patient UID, I'll zoom in, and a username, and that username is just the first and last name put together. And but the PIN number is unique to them. So this information needs to be given to the patient in some way, and different clinics have different policies on how this information is communicated. So a lot of clinics just choose to send this by text message, some over the phone, some print it out and give it to them in person, or some kind of send it out over email. We do have this feature here which allows you to kind of generate a PDF, and that includes all the login details you need. Most clinics I've spoken to do use this feature. I think Jeremy's clinic in particular don't like using this feature, ultimately because it includes the username and the PIN together. Again, that's just a policy that the clinic can decide on. But this tells you how they can download the app, and failing that, if they don't have a mobile phone, they don't want to use a mobile phone, they can use this URL link. So using this information, the patient would then be able to access the app, or for today's demonstration, I'll use the web app. So you can just click here, this opens up a kind of brand new tab here, and essentially what you're seeing here is a web-based version of the mobile app. So everything you're seeing, everything that you would see in a mobile app looks exactly the same as it would do on here. I think I'm going to show you this one. So if you want to use these login details to log in, click login here, and this logs in essentially on behalf of the patient. So to start a new assessment, you just click here, and this would then kind of display all the available kind of PROMs that are on offer to the patient. And again, these can be customized. But if I just show you the C19-YRS initially, we've got first kind of compulsory questions around consent to research. So this is just asking whether or not the patient is happy for the clinic, for the individual clinic to use their data, for example, for NHS reporting, for any clinical research which is used internally, and whether or not they'd be happy to be contacted. We do often get asked on whether ELAROS or the University of Leeds, for example, accesses that data. The straight answer is simply no. If you are participating in research or you wish to do participate in research, you can get in touch and we can kind of support that. But if I just show you kind of quickly the first page on personal information, this asks a couple of questions on demographics factors such as medical history, height and weight in imperial and metric units. So if you just simply type it in one kind of unit, it'll automatically calculate the other. We've got kind of the 5 high-level ethnic groups which are asked for by NHS improvement. Clearly there are kind of more granular categories, but these are the 5 groups that NHS are asked to report on every 2 weeks. Smoker status, which can change over time. Just questions around kind of when they first started experiencing symptoms, which essentially provides kind of an estimate on when they first got infected, because a lot of clinics are kind of accepting referrals of patients that do have essentially unconfirmed COVID, that have had an unconfirmed case of COVID. Okay, so all these initial questions are optional. But if we move on to the question 1, anybody who is familiar with the C19-YRS will start to kind of recognise some of these questions, and hopefully you know how this works. But for those that don't, with the YRS, we ask patients to grade the severity of each individual symptom at present day, and to do this we use a kind of sliding scale on a 0 to 10 scale. And on the very first assessment, we also ask them to provide or try and recall the severity of those symptoms from before the COVID infection, which in most cases it's either a 0 or a 1. This essentially kind of provides a baseline for the patient and the clinician to kind of work together and try and kind of bring those scores down by kind of engaging with rehab programs or with treatment. But in some cases, for those patients perhaps with underlying health conditions such as kind of COPD, asthma, or kind of mental health symptoms, certain symptoms might be scoring a little bit higher, such as a 2 or a 3. On this particular question, we ask about breathlessness in different scenarios, such as on dressing yourself and on walking up a flight of stairs. And in order to kind of improve kind of adherence with the questionnaire or compliance with it, if there are any kind of questions that are left unanswered, we automatically prompt them just to say, make sure you scroll down and complete every question. This is just to kind of let them know that there are questions that are still kind of incomplete. A good example is those that have a small mobile phone screen or that might have just simply missed it. So this kind of prompts them to go back and complete that question. So you can see the red highlighting is then being removed. But if there are questions that they simply do not wish to answer, they're not sure how to answer, or they feel uncomfortable in answering, we can just click I do not wish to answer. Question 2 here is just to show you kind of we do have multiple choice answers. So on some questions we ask, do you have 1 or more symptoms, such as in kind of relating to cough here, so you can tick 1 or many. And on other questions, they are just single choice answers, so you can just tick 1, such as which of these is the worst. I will jump to question 9. So this is one slight modification that was asked for, I think by Jenny from Leeds. We do add a prompt here, which is saying, are you thinking about self-harm? If you are thinking about self-harm, please speak to your GP or call 111 or 999. But for the purpose of this demonstration, I won't kind of go through the full questionnaire, as we've got a lot to show you. I will quickly show you the EQ5D. So this does look quite different. This was kind of one of the licensing requirements from Europol as a condition of us adding the questionnaire into the app. So this looks slightly different. It is much shorter, but this obviously only covers the 5 domains of the EQ5D, and it doesn't touch upon a lot of those other symptoms which the C19-YRS does. For those that are familiar with EQ5D, you know that this vertical analog scale is required. So this essentially allows the patient to kind of give an estimated global health score. Okay, so once an assessment has been completed, if you are kind of completing an assessment on behalf of the patient, the member of staff would need to log out and then they would log into the next patient if completing a telephone appointment. So if I'm now showing you kind of what this looks like for patients who have already completed multiple assessments. So this one, this demo patient has completed 18. If I then quickly show you the C19-YRS, you can see that this first page has now been shortened, so we don't need to ask about height, ethnic group, those test results, as these things don't necessarily change. Whereas things like changes in weight, smoker status, medical problems, the required hospital admission, these things can change over time, and that's important, or it can be useful for staff to know. If I just show you this one, so on subsequent assessments now, we no longer ask about the pre-COVID scores anymore. So ultimately, the questionnaire has been almost halved. So this allows them to kind of work through it a little bit quicker, just to kind of help with that compliance. Patients will also be able to kind of view all of their kind of assessment history in this assessment archive section. So this essentially shows you kind of a log of all the assessments that were completed by the patient. So if I want to look at the very first assessment that this particular patient looked at on the that they completed on the 30th of April, this is the very first assessment, YRS assessment, and they'll be able to kind of scroll down, look at all the questions, sub-questions and answers that they gave. But for quite a few patients, as you can imagine, this might be quite text heavy, a little bit burdensome, a lot to make sense of. So for the C19-YRS in particular, we do have a charts feature. And essentially what this is a radar plot overlaying all the kind of assessments and the severity scores that they gave over time. So this is interactive. Clinicians do have access to this in the web portal, and I'll show you what that looks like later on. But patients can essentially kind of see how this kind of this plot or this chart helps them to kind of understand, or it provides them with an overview of how these symptoms have kind of improve or deteriorate over time. And in some cases, these symptoms they can fluctuate, so some of them might get worse. But I do have a patient user story at the end, which will kind of essentially give you some feedback, and kind of you'll hear from a patient how they found the charts. But this is commonly reported as quite motivational, somewhat empowering for the patient, as it helps them to kind of understand exactly where they're at right now, and essentially to engage with these rehab exercises, treatment plans, etc. So we do group together questions 1 to 10 to give a symptom severity chart, and this provides a summative score in the web portal, which Manoj just described. And we group together questions 11 to 15 to give a functional disability chart. For those clinics that do wish to use the modified version of the C19-YRS, we do have these charts as well. And the key differences, as we've described, is that this uses a scale of 0 to 3 rather than a scale of 0 to 10. And this includes lack of smell and taste in the core 15 questions, palpitations, and also post-exertion malaise. Okay, so as soon as an assessment has been completed, this is then sent back to the web portal. So if I find the exact same patient, Joseph Bloggs, you can see that these fields have automatically been populated now. So essentially, a clinician or member of staff would have access to all that information prior to the patient's next clinical appointment. If I show you kind of assessment graphs and these comparison graphs, you can see now this is what essentially the clinician has access to. And if I show you kind of what the EQ5D graphs look like, you can start to see how these build up over time. So we've got the MRC, the PHQ-9, the WSES score, and there's an opportunity here to kind of add additional PROMs. Each PROM has a kind of unique kind of scoring mechanism. So it's got a different kind of summary table, graphs, charts, scoring tables. But if I show you the YRS as an example, this is the kind of table that Manoj showed you in his presentation. We've got kind of some column headers which show you the summative scores, the overall health scores, and the date at which each assessment was completed. We've also got the same for the EQ5D here. And we often get asked about clinics who are already using the C19-YRS on paper or as a telephone screening appointment, as a screening tool. We do have a feature here which allows you to kind of add historic assessments, so these can be uploaded. Essentially, why this is useful: if there's a patient who's already completed 2 YRS assessments on paper and then now want to kind of start using the app, you do have the ability to kind of add those previous assessments, log on to the app, and these same charts and graphs will be generated within the patient app, and they can essentially continue from assessment 3 onwards. As I say, each PROM has like a unique scoring mechanism. So for this one, we've got a different kind of a score breakdown table, and this plots kind of the pre-COVID scores against the present day scores. This is where you look at kind of the severity of other symptoms, and we've got kind of a full assessment list here, and this shows you kind of the full assessment report. And this is essentially what would be exported and uploaded to System 1. I believe with Rio, if there's anybody using Rio, I don't think that it accepts attachments, but we do have the ability to essentially download each assessment as a CSV file. I think this is also commonly used in EMIS as well. So we do have like a range of kind of features that kind of support or facilitate this kind of data capture and then exporting and uploading to things like EMIS, EPIC, System 1, etc. And just to show you kind of what these CSV files look like for the individual patient, for the YRS only, this essentially gives you access to all the raw scores for that assessment. For that patient. For any commissioners or kind of service coordinators that are interested in using the system, you can also access all the raw data of these demo patients. They've all been kind of recorded in the web portal. Okay, I'll come to my final point here. See if I can make this full screen. Okay, so this is just kind of an emulator version of the mobile app. So it's similar to the web app, but this is just the best way of describing this. So we do have a new feature here called support resources, and essentially this includes a lot of high-level sections on various kind of support resources which cover these different symptoms. All of this kind of content that's been built into the app has been provided to us and produced by kind of clinics such as Leeds, Airedale, Salford. The Sleep Charity have given us some content that's going to go in. And we're discussing with all our kind of clinical partners across the country to essentially provide additional resources that can be kind of packaged into this app. So to show you this example, if I wanted to open up the anxiety resources, I can click here, and this essentially opens up a screen within a screen. And this essentially opens up an anxiety resource. And this section in particular has been provided to us by Salford Royal. And these kind of sections can be worked through. There are some exercises along the way. There are some downloadables, but a little bit more about this platform on the actual website itself. Where are we? Essentially, this is a new platform that we've developed. You don't have to use the app to access this website, but naturally, patients who are using the app to record the symptoms, it's just their nature that they want to have everything packaged into one place, so they can access this content within the mobile app. So I'll try and rush through this now, but essentially there are some downloadables which kind of members of staff can access themselves. So we've incorporated some of these booklets that Rachel, Jenny, Jeremy have all kind of provided to us. But I think the one that's quite useful is we do have a translate plugin here. So essentially we've added all the kind of most commonly spoken non-English languages in the UK, and you can instantly kind of translate all this language and all this content into different languages. Be really conscious of time now, so probably will stop there. And I think I'll just round off with this patient interview at the end.
But they're trialling a long COVID new app. Kelly Foran met up with one of the first people to use it. This, busy hospital wards, an image we're used to seeing when we talk about COVID. But for Sarah, it's in her everyday life. She manages the Opera House in Manchester and is still suffering with long COVID, as are 1.1 million others. They fill out this theatre every night for nearly 2 years.
I've suffered throughout the last 18 months with constant pains in my head, pins and needles in my arms and legs the majority of the time, and as people say, you know, the brain fog situation.
Yeah, so you've had some tough days, I assume.
Yeah, I mean, some days have been worse than others. There's been occasions where the joint pain, particularly in my knees, like you couldn't actually get up off the sofa.
How is having this app, do you think, going to help you going forward?
I like it because obviously you don't have to go for an appointment. You don't have to go to the doctors or anything like that. You can just do it wherever you are. So obviously for me, I did it at work.
What's the process? What have you had to do so far?
So far I've filled in a survey which literally asks you lots and lots of questions about how you've been suffering, what your symptoms are and things like that, and you have to score it on a 1 to 10 basis. You then, someone rings you to just go through all your answers, and then that will get reviewed by a medical board.
And you've got a busy job here at the Opera House and at the Palace as well. How are you feeling about things going forward?
I mean, I absolutely love my job, and I've done it for such a long time that, you know, the excitement that comes with working in theatre, it helps you overcome the pain and the symptoms that you're actually suffering, because it's quite medicinal in a way. Yeah. So it gets you out of your house, it gets you out of home, and takes your mind off things for a while.
Yeah. Oh, good for you. It does sound like the dream job. I hope you feel fully better soon.
Thank you.
Kelly Foran, BBC.
I think I might have overrun it slightly there, but I hope that's captured everything.
Brilliant. Thank you very much, Roman. I think that's provided a really useful overview as to showing exactly how the system is used from a patient's point of view and a clinician's point of view, and how straightforward that looks from a patient point of view as well, and intuitive. It's really nice to finish on that patient story as well, so you can see the real benefits that have been seen by patients. I think there were a couple of questions in the chat, kind of linked to one of the points that you made around the resources that you're putting in there. There's a question around if you would be putting in or if resources could be put in that were linked to a particular locality services and so on, so to provide emotional support and signposting. For example.
Sure, we do have plans to address this. I suppose how this might work in practice ultimately. A lot of clinics have a lot of resources on fatigue and on breathlessness, and they might want their patients to access their own resources. So we are looking at ways of essentially kind of individualising the patient experience per centre. We don't want to kind of say that Leeds resources are the best, or just because we've got Salford's before anybody else's, we don't want to kind of patients from seeing their local clinics resources. So we are looking at ways that we can kind of individualise it for them.
Yeah, excellent. There's also a question around if you carry a CE mark or a UKCA mark as well. So just around your regulations there.
So we are not currently CE marked, and the reason for that is because we are not a medical device. It doesn't include any predictive analytics. We don't diagnose any patients, or the app doesn't diagnose any patients. Ultimately, this is a kind of partner to the clinicians. It's like your partner in health management is ELAROS' slogan. This is essentially kind of providing the clinicians and the clinical team with all the information that they need to kind of progress with the delivery of care for that patient.
Brilliant, thank you. And there's another query as well around when you think you would be integrated with System 1.
Sure, that's a tricky question.
It is, yeah.
We can ask this question from all the team EMIS, from all the team RIA, from all the team EPIC.
Yeah.
We have had some positive news from Innovate UK. They've actually provided funding and agreed to kind of part fund the interoperability and integration of the system with a electronic health record. We will be prioritising EMIS and System 1 first. I hope that's going to satisfy the majority of people here. RIA and EPIC will come later, and other kind of EHRs there, but ultimately these are the most used systems, and they're the ones we're going to tackle first.
Yeah, okay. And there may be some requirements here around the size of service and so on that places have, but are you able to share any information on costings for NHS trusts?
Sure. Ultimately, this kind of depends on the size and like the local pathways. We do have a kind of standard figure of 8,649 per trust. This was agreed and kind of formulated by kind of in collaboration with Leeds, with Liverpool and Salford. It is a not-for-profit project. This whole kind of project or initiative is kind of a not-for-profit initiative, but ultimately, like in cases where Jeremy are acting on behalf of Bradford, or if I give the best example of Liverpool, who are acting on behalf of 9 trusts in total across the wider ICS, we do kind of factor that in and kind of agree on something that's fair. Because ultimately, this is going to kind of fund the future development, the things like integration with EMIS and System 1, etc. So we can have that discussion, I think, with each individual team.
Brilliant, thank you. Are there any other questions from the audience for Roman?
Can I just say there was one question, Roman, from Helen, I think, asking, can the platform be personalized, local service contact details and signposting? Can that, for every service, can that go into the system? I wasn't sure of that.
So in terms of local service contacts, so we are working on a clinical appointments feature where essentially a member of staff would be able to add, for example, when their next appointment is coming up. And somewhere in the more section, we'd say, kind of, this is when your next appointment is, this is who you're going to be seeing, at what time is that? And we kind of will be building in kind of automatic kind of patient reminders, making sure that everyone's completing the YRS on time. But these notifications will also be kind of configurable per PROM. So for those that are using the EQ5D as well, or the PROMs, they'll have kind of automatic nudges based on which PROM is due next, if that makes sense.
Thanks, Roman. I think what I was meaning is when obviously the pop-ups came earlier, say somebody did need to source help and it said about like any concerns around self-harm and things, would you be able to put like local mental health crisis teams rather than it being just a generic national number, or even contacting your local long COVID service? Would you be able to put your own service contact details and things like that?
Yeah, it's definitely possible, and kind of that goes back to one of my initial points about kind of personalising or individualising the support resources for that patient. So if there's a patient from Blackpool and Blackpool has those support resources, there's nothing stopping us from adding in some additional kind of criteria or information just to access the local IAP service or kind of Samaritan's hotline. That's definitely possible.
Brilliant, thank you.
Thank you. And there's a query in the chat around who is the best contact at ELAROS to discuss looking into using the app in future, which I would imagine, Roman, is yourself.
Yeah, but we had a few inquiries, so we'll put in our kind of support contact detail there.
Yeah, I'll pop that in the chat. Ah, you beat me to it. Excellent. Are there any other queries from the audience at the moment? Okay, so I think I'll follow up with some additional information after the session, and just take the opportunity to thank everyone for attending today. And it's a really busy time, so we really do appreciate you attending. Roman's pops the contact details in there for ELAROS if you wanted any more information directly. And I think a big thank you to everyone who shared information today around how you've implemented the service and how it's been used. It's been a really, really informative session. So thank you very much for attending. Thank you very much, everyone.
Thank you very much.
You all, thank you.
Thank you.
Thank you, Sophie.
Thank you.